Hey guys, welcome back to Quick Nursing Shorts with Smita, and today we will be dealing another topic from digestive system. The disorder is cancer of the esophagus, and it's moderately important for your examination. So here it starts with the definition. The esophageal cancer is a malignancy that develops in tissues of the hollow muscular canal that is called esophagus, along which food and liquid travel from the throat to the stomach. So, since we call it cancer, so it's a malignancy, and yeah, it's a malignancy which is happening in the esophagus, which we also call it as food pipe. So, this is the definition. I hope the definition part is clear to you all. So, we are moving on to the etiology and risk factors. So the etiology, it's not, it's kind of idiopathic, which is unknown. But yeah, there are some risk factors which can cause this cancerous in esophagus. So what is it? The first thing is chronic irritation. So let me take my pointer. Okay, so yeah, first is chronic irritation. So what is chronic irritation? Once the person start feeling a kind of irritation in their throat or esophagus area, and if it persists for a long term without getting any medical treatment or care for the same, the person have the chances of getting changing the problem might get changed into a cancer. And the second thing is ingestion of alcohol. If you are taking alcohol and like heavily intake of alcohol, it's not that slight intake, but we can't say that it that everyone who takes alcohol will be at the risk, because there are some people who are completely sober, they don't take alcohol at all, but still they get this cancer problem. And then use of tobacco, as we all know, tobacco causes cancer. It is well known. Now the other risk factor is there seems to be an association between GERD and adenocarcinoma of the esophagus. Adenocarcinoma is nothing but the cancer. It's a synonym of cancer which you can use. So we have already dealt with this topic GERD in our previous class. So if the person is having GERD, that is gastroesophageal reflux disease, if the person has this GERD problem and they keep on getting like recurrent GERDs happening with the patient, and they are not getting proper treatment for the same, this GERD might get complicated and turns into a cancer of the esophagus. And the next and last risk factor is people with Barrett's esophagus. So Barrett's esophagus is another disorder of esophagus, and this is also a complication of GERD or maybe the gastritis complication. When the person esophagus is irritated by something or eroded, as I have taught you about gastritis, then esophagitis, I didn't take the class for that. But yeah, if the person is having esophagitis, gastritis, and GERD problem, the complication is Barrett esophagus. So when the thing get more complicated, more worsen, we call it as Barrett esophagus. So this is another risk factor, and there are some other risk factors as well, which is not that important to show in this slide, which I haven't. But if you see any of other risk factors in your book and you feel that it is important and you can remind it during the examination, then do write it in your exam. Okay, so moving on to pathophysiology. And pathophysiology starts with, I have written it in very small, you can see it's very one word or one two words I've only taken. So if you want and you have proper time when you are writing the exam, because in nursing I have faced this thing that many students, they leave many questions behind. Maybe they don't get proper time to attempt all the small questions and very small questions. So this is the problem, because they don't have proper time management. So even if you write pathophysiology as I have written it here, it's gonna give you proper marks. They won't be canceling any of your marks with that. But you need to make sure that you are writing the whole, like a long answer. When you start writing, you need to write all the content outlining, which I have subdivided into headings like pathophysiology, definition, etiology. You need to mention everything. Okay, so yeah, pathophysiology start with normal epithelium, which is normally everybody has. So when this normal epithelium it's a normal epithelium of esophagus. When it gets inflamed or some infection happens, then it turns into esophagitis. And after esophagitis, there will be metaphasia, like uh, the perforation of esophagus. And because of perforation, it will be completely eroded, the erosion will be badly happening over there, and the person might be facing the problem of irritation and regurgitation and all those. So yeah, gradually it all happens. So once it is not being treated at the first level, it's gonna advance to the next level, which is Barrett esophagus. After esophagus, there will be low grade dysplasia. What is dysplasia? Dysplasia is, again, it is multiplication of the cells, or multiplication of that proper the cell which is affected. Okay, that affected area will be multiplicated, and then there will be a high grade dysplasia. So if you have already learned about cancer, so you might be knowing all these terms, dysplasia and hyperplasia, and also there are some terms in tumor. So first there will be low grade dysplasia and then high grade. After that only it will form a proper cancer cell in your esophagus. So this is how the steps are. So first it will be a normal epithelium, which will be because of some risk factor and some etiology, some causes, it will lead to esophagitis. Then esophagitis, well, it is not treated in time, it will turn into a Barrett esophagus. When Barrett esophagus is not properly treated, or maybe the treatment is being taken but it is not showing successfully, like it is not being um, it is not being useful for the patient, you can say. And then it will turn into low grade and then high grade dysplasia, and ultimately the person will be facing this cancer issue. So once it is cancer, you know how difficult it is to be treated. There is treatment, but again the problem is that if early stage cancer is found, we can treat it because our main purpose is to cure it. But if we are finding out cancer in the later period, then it might be very late for the patient to get saved. So maybe we just can fa- um, we can just see how they can just subside this, how we can subside their symptoms. Yeah, this is what I meant. So this is pathophysiology. I hope the pathophysiology part is clear to you. If you want, you can just not write only these single words, you can write, you can just complete this word. Okay, you can complete, like here next to the arrow you can write etiology, due to cause or due to risk factors. If you know any, like you can write in bracket like alcohol and tobacco. Then esophagitis, again you can write something here, like unsuccessful treated, or unsuccessfully yeah, treatment wasn't proper enough. So like that you can just give your point also, and then you can write in a same pattern, you'll get good marks. Now moving on to the other subheading, which is clinical manifestation. Clinical manifestation, how it is. So I have divided into early symptoms and later symptoms. As I told you, in tumor and in cancer cases, this is mostly happens that we might think that this is another problem and we might get treatment for the other problem, but we are not actually having the same thing, right? So early symptoms would be dysphagia, so difficulty in swallowing, because esophagus um, is in a bad condition, so the person will be having this difficulty in swallowing. So initially the person will have the difficulty with eating solid food. If you are taking chapati or roti, and you might feel like it feels very sore when you swallow it. And eventually, even when like after some times, you will feel that even the liquids, when you are taking the liquids, when water or anything juice, that will also feel like it's very difficult to swallow. And then a sensation of mass in a throat. And when the case get worsen more, and the person will start feeling that there is something stuck in their throat, and they will feel like, okay, something is there, and something is some obstruction is over there, the person will feel like that. Then painful swallowing, the same thing, dysphagia. So the person will feel difficulty in swallowing. And then substernal pain or fullness, the person will feel like the over the sternum region, the person will feel like there is a kind of fullness, that they feel like anorexic, that lack of appetite. They think that their food is not being digested and their stomach is full, so that feeling of fullness will happen. Then comes later symptoms. Later symptoms might be regurgitation of undigested food with foul breath and hiccups. So we have seen these symptoms over there in GERD also, if you guys remember. And then intermittent and increasing difficulty of swallowing. So why we say intermittent and increasing difficulty? Because difficulty was there in early stage, but difficulty wasn't that much difficult. So yeah, the person keep on facing this issue that the food is not being swallowed properly and they feel the pain. So this difficulty will get increased over time as the tumor progresses. The obstruction becomes more complete. Like previously, like initially they feel that there is a kind of obstruction, but still they try to take water and they try to take food. But in later stages, what happens, this obstruction feels like there is, it's completely obstructed and nothing is going down the esophagus, so everything is remaining over there, like that the person feels. Even liquids cannot pass into the stomach because there is a proper obstruction. And if you know that what is cancer, cancer is nothing but it's outgrowth of cells, and there are some extra masses present in that particular organ or in that particular area. So the liquid, even the liquid will not pass through the esophagus into the stomach. Then regurgitation of food and saliva will occur, whatever food they are taking, because there is no place to advance that food via esophagus. So there will be regurgitation. Whatever you eat, it's gonna come back to your mouth, and hemorrhage may take place because there is no space. And if you keep, like if you try to eat, it's gonna push that area, like it's gonna push that mass. So there is chance for the hemorrhage. And then progressive loss of weight and strength occurs from starvation, because the person is not able to eat, there is a kind of fullness and there is obstruction, person feels like they don't have any space in their stomach to take food, so they won't be eating, they'll be starving. And there you can see there is a huge um, changes in their weight. Like within few weeks they will lose a lot of weight. Okay, then substernal pain is gonna persistently remain, and hiccups are gonna also worst here. And then respiratory difficulty and foul breath. Foul breath will happen because the food is not going down, food is going to remain over there where it is. Then person will have foul breath, and the breath will be smelly, it will be very bad in smell whenever the person talks or breathe. Then respiratory difficulty will also happen, because if you know the anatomy, you know where the esophagus is. Esophagus is in your chest area, right? It is there located. So when there is a mass over there in the center, the lungs will also feel kind of heavy. So because of that, there will be a respiratory difficulty. Then the delay between the onset of early symptoms and the time when the patient seeks medical advice is often 12 to 18 months. Just imagine, 12 to 18 months is almost more than a year, or like 1.5 years. So it takes 1.5 years for the problem to get noticed, or the person to actually go to the physician and get treatment. So you can imagine how late it is to reach to the emergency. Now, anyone with swallowing difficulties should be encouraged to consult a physician immediately. Now, as you guys know, that this problem is actually a big problem. So if there is anybody who has this swallowing difficulty, just ask them to go to the hospital, take the emergency treatment then and there. So these were the later symptoms, and now we'll be moving on to the next subheading, that is assessment and diagnostic findings. So first of all, history collection, that is your prior duty once you go to the patient, because once a nurse go to the patient, they have to take history, right? You have to ask the patient about their demographic data, and then past medical history, present medical history, surgical history, everything you need to ask there. And then physical examination, that's a must part you have to do as a nurse. So assess them. And in physical examination, I think you guys already know what all the assessment we do. Assessments are like inspection, palpation, percussion, auscultation. So yeah, we are gonna do all these four things to any patient who comes to you. Then endoscopy. Endoscopy is mandatory in any esophagus disorder or in any upper digestive system disorder. So with endoscopy only, we are gonna get a very clear picture and a very good visual presentation. Then comes biopsy. So I told you in the last class also, when you say see a word called cancer, or when you are suspecting a person that they might have cancer, the doctor will write for biopsy, and then the doctor will, maybe during the endoscopy process itself, they will take a part of tissue or a small particle, and they must just do scrapping and scratching, and through that they'll get the biopsy. With biopsy we'll be identifying whether it's a cancerous, it's a malignant tumor or it's a benign tumor. Okay, then bronchoscopy. Here, why we are doing bronchoscopy? Because bronchoscopy is something happening with the lungs, right, with the respiratory system. But here in later symptoms we have noticed the person is also facing a respiratory difficulty. Person is facing dyspnea, difficulty in breathing. So we have to go and ask the patient to go for bronchoscopy. Patient has to go through bronchoscopy just to get to know whether if there is any problem with the lungs, or there is anything happening in trachea also because of the cancer present in esophagus. As you know, there are these cancerous cells might get spread over in other places of the body. They could be metastatic. We say a term in medical that is metastasis. So yeah, there might be a metastatic cells. They might go anywhere. So yeah, you have to do another thing, another test, whichever is appropriate that time. And the next thing is endoscopic ultrasound and mediastinoscopy. So endoscopic ultrasound is the same thing, that we are gonna visualize the mediastinum part, why the person is having this feeling of fullness on their sternum, and why they're having sternal pain. So this is all we need to do. And one more thing, history collection and physical examination, these two things are the must. You, whichever condition you get in your examination for long answer or short answer, if you are writing the diagnostic findings, make sure you, first of all, you have to write history collection and physical examination. After that only you go to the other diagnostic criterias which has to be done. Okay, so I hope this part was clear to you. So if you have any doubts, you can just comment down and I will give you another class, or maybe if I can provide you some with something else. Yeah, so then moving on to the medical management. Medical management, if the esophageal cancer is found at early stage, yeah, if it is found at early stage, the treatment goals may be directed towards the cure. Because on early stage, there are more chances and there are more criteria, more treatment criterias are available. So, however, it is found in late stages, making relief of symptoms is the only reasonable goal of the therapy. Because in late stages, there could be a lot of thing happening in the person's body, and maybe things had got so worst. And in that case, only the relief and subsiding symptoms, that will be our only choice. So, this treatment may include a surgery, or radiation, chemotherapy, combination of these modalities depending on the extent of the disease. So some person who has this cancer issue, they get chemotherapy for sure. They have to go through a chemotherapy, and if it's applicable, or if the person's condition is bit complicated, then we will be combining these two modalities, radiation and chemotherapy. The person will go for radiation as well as they will be on chemotherapy, and if required, then surgery. Even after surgery, the person has to go with the radiation therapy, because you have to, even after resecting the cancerous tissue from the body, the person should get radiation therapy for once or twice, 2 or 3 cycles they should be getting, to make sure that the remaining, if there is any remaining cell or cancer cell is present, then through radiation we're going to kill that too. So this is about medical management. Then moving on to the surgical management. Surgical management is total resection of the esophagus, total resection. So here it says that if the esophagus, whichever part of the esophagus is being affected, wherever the cancer cell is present, we can just remove that area, or we can remove that tumor along with the whole esophagus. And the term of resection of esophagus is esophagectomy. Esophagectomy. Yeah. Then a segment of colon may be used, or the stomach can be elevated into the chest, and the proximal section of the esophagus anastomosed to the stomach. So once you just imagine, there is esophagus and then the stomach comes. So when there is no esophagus, so obviously there must be a left behind part, right? There must be a left part of esophagus, maybe very small, but yeah, there is a part. So you have to, when your resection is happening, resection will not completely happen like cutting esophagus and then coming directly to the anal region. No, only the esophagus part will be removed, and the remaining part of stomach and esophagus, they will just anastomose. Anastomose is again a medical term. Anastomose means fixing or fusing together. Okay, so here they'll be fusing it. Maybe they'll just take a segment of colon, and with that colon they'll be anastomosing the stomach proximal section, or the stomach area and the proximal section of the esophagus. So anastomosis and total resection of esophagus happens here. Then complications might be, because there are, even for the minor surgeries there are complications. Excuse me. So surgical resections of the esophagus has a relatively high mortality rate because of infection, pulmonary complication, or leakage through anastomosis. So resection, I'm sorry, surgical resection. So after this, what happens? There is a high chances of death rate, that the prognosis is poor. So because of why it happens, because maybe maybe the infection catches, or there might be a pulmonary complication occurring because the respiratory system and digestive system is quite close. And then when where we are doing this anastomosis, we are fusing the stomach area and esophagus part, there might be a leakage through that, and then infection will occur. So this is the complication. So moving on to, yeah, there is something else also here. So cues. Palliative treatment may be necessary to keep esophagus open to assist the nutrition and to control saliva. Yeah, palliative treatment, you can see palliative treatment, this term, everywhere, wherever you read about cancer. So these cancer patients, they have to go, even after the surgery, they have to go through palliative treatment. So palliative treatment is something which happens after that, and we just try to um, give a good quality of life to the patient through palliative treatment. Okay, then palliation may be accomplished with the dilation of the esophagus. So yeah, how that word dilation of the esophagus, I'll just show you the picture in later slides. So there is a picture of dilation of esophagus, how it happens. So palliation may be occurring with that. So through dilation, we make sure that the esophagus is widen and the food goes through there, and the person, after some times, the person can live a normal life like any other person. So yeah, laser therapy is there. They will be using laser therapy. Then placement of endoprosthesis. Endoprosthesis is, they're talking about prosthesis word. Okay, prosthesis is something um, which is not natural. Prosthesis is something duplicate thing we are fixing on there. So we can use stent to dilate, or we can use a balloon to dilate the esophagus. Then radiation chemotherapy, every cancer patient has to go through radiation and chemotherapy. And it happens like throughout their life cycle, they have to go through it. So because the ideal method of treating esophageal cancer has not yet been found. So it says that uh, the proper treatment, the ideal treatment, that this is not even found till now. So what we can do is giving chemotherapy, medication, radiation, surgical treatment. We are doing all these things, but but one and only treatment is not being identified yet for this problem. So next is post-operative complication. Post-operative complication is, it could be after, uh, post-operatively after the surgery, patient might feel aspiration pneumonia. There might be a aspiration and fever due to infection. It can they can catch infection also. And then seepage of fluid through operative site, like where the operative site is, where we have anastomosed, maybe there is a seepage or leakage from there, so that could be complication. And it's not a small complication. These complication can complicate the person's life. Okay, so next is nursing management. Nursing management is improving the patient's nutritional condition. So this is what we do in nursing management, right? The basic things, and you say the most important things. So improving the patient's nutritional condition, preparation for the operation. The person has to go and have operation, then you have to teach them, you have to make them ready for the operation. And then a program to promote weight gain based on high calorie and high protein diet in liquid and soft form, because the person cannot take a solid bolus of food. So we can have them, we can refer them to a dietitian. A dietitian can give them a proper diet plan. Then if not, if contraindicated, if the above thing is contraindicated, taking things orally, if the person is NPO, then you can go for parenteral and enteral nutrition. So parenteral nutrition is, we say TPN, total parenteral nutrition. So the way we infuse IV fluid, intravenous fluid to the vein, in the same way we start TPN also. But in TPN, it's not only the glucose or DNS or NS or RL. It's a nutritious diet. It's a all nutrition, altogether nutrition in a liquid form or in a water form we are providing to the patient through their cannula. Now, teach the patient regarding closed chest drainage, nasogastric suction, parenteral fluid therapy, and gastric intubation. So, why you have to teach the patient about all these things? Because once the patient had surgery, the person have to go through a closed chest drainage. So, these things are the procedures the person has to go after surgery, and it is important that the patient already knows about the procedure they have to go in future. So teach them very well what is closed chest drainage, how it happens, how long it takes, and what all the precautions we are taking to prevent the contamination and infection. And then nasogastric suction, you have to do nasogastric suction also, because you can't just do it from because the person cannot, they might be having problem with spitting and they might be having problem with eating. Then through nasal you need to do the suctioning. Then parenteral fluid therapy, how this parenteral fluid therapy works. So you have to teach the patient that it's a nutrition which we are going to infuse in your body through the vein. And gastric intubation, because the person will be on NG tube. So they'll be getting the feed, everything through the NG tube, all the liquids. So you have to teach them that the nasogastric tube is a tube which goes through nasal cavity, and then from there it goes to the stomach area, and through that they are getting going to get feed. So everything you have to teach the patient about all these procedure. If the patient is placed in a Fowler's position, and later in the initially the person, you have to place them in a low Fowler's position, that do not raise the bed head end of the bed a lot. Just put it into like 20 degree, 10 to 20 degree. That's a low phallus position. So person will be on low phallus position initially because they has had a surgery. And later when maybe after few weeks, you can just give them phallus position, like proper phallus position, like 35 to 45 degree. And then to assist in preventing reflux of gastric secretion, because there is a chance of GERD, that regurgitation, there is a chance for that food or maybe secretions to come back to the mouth. So we have to give them follow position. Then if jejunal grafting has been performed, jejunal grafting, if it has been performed for the patient, then assess for the presence of pulse by means of Doppler ultrasonography. If the grafting has happened, so you have to make sure in that grafting area there is the pulse is present, because because I, even in my when I was working, I have seen that few patient on their grafting area, you can feel the a rush. Okay, you can feel a blood rush. For some patient, the pulse, you can't even feel a feeble kind of pulse. So this pulse is being made sure with this Doppler ultrasonography, which is important. Okay, you have to make sure that there is a pulse present. Then ensure the correct placement of NG tube post-operatively. So post-operatively, patient is on NG tube, nasogastric tube, and in you have to see, you can see the NG tube also through X-ray. Take an X-ray of the patient, see where the tube is going, whether tube is in place, and if the tube is misplaced and you see that the gastric content is not going in, or when you are trying to aspirate, you see that something else is coming instead of gastric content, you see that the aspiration, nothing is coming out, it's just water, or maybe the whole food is coming out, there is no digestion taking place. In that case, as a nurse, you should not try to reinsert that tube in place, okay, because it can cause further damage or further injury to the patient, which you do not want actually, right? So you have to ask the doctor to see, and then a very trained person should perform the reinsertion, that too under physician's supervision. Then NG tube is removed 5 to 7 days after surgery and a barium swallow is performed. So, and when the NG tube is being removed, maybe after a week, and whenever doctor says that it's applicable to remove, we can remove it. But after removing it, also we have to perform a barium swallow. Barium is barium is a chemical component, so we ask the person to drink barium. It's a watery thing, so it's a mix with water. So we'll ask the person to drink barium, and then we have to assess for any anastomotic leak before the patient is allowed to eat. So once you take out the NG tube, person has to start eating food. It means the person is able to start food by their mouth. That's the reason you are removing the NG tube. But before you do that, because we have already manipulated their esophagus and their whole digestive system, we have been manipulated. So we have to ensure that whatever the person takes by mouth, it's actually going into esophagus throughout the digestive system. So for doing that, we have to ask the patient to swallow barium. Barium, it's a radiographic element, and then once we take the x-ray of that patient, we can just clearly see that yeah, it's going nicely down. And if it's being obstructed, that also could be found in the x-ray. And then again, if needed, again the person has to go for surgery, or if it's good, then it's well and good for the person, then they can start eating by orally. Then give health education to the family once the patient is ready to go home. So now when patient NG tube is removed, patient starts eating food very well, and they are doing their range of motions, everything is good, person starts to walk. Now it is the time that you give a proper health education regarding their food, regarding their bathing, and how they are going to dress, everything you have to teach their family members before sending the patient to home. Now, provide a diet plan to be followed by the patient. So you can just ask the dietitian to make a diet plan for the patient, and if there is any changes, then the dietitian can make the changes before the patient leave the hospital. Now, the nursing diagnosis. Nursing diagnosis: imbalanced nutrition, less than body requirement related to difficulty swallowing. Imbalanced nutrition is something you can write in all the condition of digestive system, not only digestive system actually. um, it could be applicable in other system as well. So you can see the if it is applicable right there, but in digestive system, for any disorder, write imbalanced nutrition based on less than body requirement or more than body requirement. Now, risk for aspiration, because we have anastomose, so there is a chance that there is for aspiration. So risk for aspiration related to difficulty swallowing or to tube feeding. Then acute pain related to difficulty swallowing, ingestion of an abrasive agent, tumor, or frequent episodes of gastric reflux. Maybe it could be pre-operative diagnosis or it could be post-operative diagnosis also. So it's this is a pre-operative diagnosis, difficulty swallowing. You can write acute pain, same thing, related to post-operative thing also you can write, because because of a surgical procedure, the person might get this pain. Then deficient knowledge of course, at last you can just to add up to your diagnosis, if you don't have any other diagnosis left, then you can write deficient knowledge about the esophageal disorder, diagnostic studies, medical management, surgical interventions, and rehabilitation. Okay, then risk for infection, this is post operatively. If the person has gone through the surgery and there is a chance of developing any infection, so yeah, there is a risk for infection. Then expected patient outcome, so this is the additional point. Okay, you don't have to write these in your examination because you won't be getting time much. There is no much time to write all these things. The additional point I have just written, I just made the slides for you to understand it well, and if it's possible then you can just write in your own words, right? So first thing is achieve an adequate nutritional intake in such patient, because it's something related to your digestive system, and person may have the difficulty in eating in future also. So you have to make sure that they are maintaining adequate nutrition. So how it can happen? So it can happen through eating small and frequent meals, drink water with small serving of food, avoid irritants like alcohol, tobacco, or very hot beverages. So these things must be avoided completely if possible. Give them proper health education and try to, I won't say manipulate your patients, but yeah, try your best and tell them all the risks and all the complication attached with these things like alcohol and tobacco. Tell them, and then give a proper health education. Then maintain desired weight. So how we can make sure that the person is having good nutrition? You can just check their weight whenever they come for the follow up. Just check their weight and always compare with the last visit weight, how much they were. And if they have gained weight, then just see in how much duration of month they have gained how much of weight. And if they are losing their weight, just it indicates that it's very imperative that you go to the patient physician and inform them that there is a drastically changes in their weight. Now does not, if the patient does not aspirate or develop pneumonia, so to avoid these things what you can do is, to avoid aspiration, give them a Fowler's position, maintains upright position during feeding, when they are getting the feeds or when they are eating. Make sure that they are in a sitting position. How we eat, it's not like sleeping and then trying to feed them. Okay. Then use oral suction equipment effectively. The person who is taking care of the patient, they should know how to use this oral suction. So it's very important to do the suction part, because the person might not, they might get the secretion because they have gone through a surgery. So that secretion is must to avoid pneumonia and aspiration. Then able to control pain within a tolerable level. So for pain control, avoid large meals and irritating foods, because this large meals they will take time, and if it's solid food and irritating food like spicy foods and peppermint is there in food, so that's gonna be irritating for the esophagus and stomach. So if you want to control pain, teach them about this. Then take medication as prescribed and adequate fluid, at least 4 ounces. The person is uh, teach them to have 4 ounces of water at least a day, and then remains upright for at least 10 minutes after taking medication. So teach them that after taking medication they should sit for 10 minutes, and maybe if they are able to walk they can just walk for 10 minutes, and after that only they should lie down. Maintain an upright position after meal for 1 to 4 hours. So they have to be in a sitting position for 1 to 4 hours, and avoid immediately lying down after eating or drinking. Then report that there is uh, less erection or chest pain. So teach the patient that if they are having a chest pain or any discomfort, they have to report it. Okay, so how they can understand the need of report? So teach them, okay, increase their knowledge level of about their condition and the treatment and prognosis. Then tell them about the causes of condition, discuss any rationale for the medical and surgical management, and tell them why their diet plan is being made, and why it is, why there is a need to be following the same diet and medication regimen. Everything you have to teach them. Why rational means you have to tell them the reason why they have to follow it. Then describe treatment programs, tell the patient what are the treatment program they are having, like chemotherapy, radiation, and and the other things. Then practices preventive measures so injuries are avoided. So tell the patient what all the preventive measures they can do, like avoiding taking alcohol and taking hot beverages and eating spicy and very hot food. So these are the things they have to prevent. They don't have to eat all these things to avoid the thing now. So this was the end, and I hope, I know that it's long topic. It's actually a big topic which I have tried making it into short. And yeah, so this is all. So we are done. And yeah, thank you for watching. And if you have any other queries, or you want me to teach you anything else or regarding something which I have forgot to mention here, you can just write down in the comments, and I will read your comments surely, and I'm gonna come up with your solutions. So study well, have a good day, and yeah, good. Enjoy. Bye bye.